Inspiratory muscles that help to increase the volume of the thoracic cavity, those are mainly the diaphragm and the external intercostals. So someone is asking, do the values change depending on how deep or shallow your breath is? That's a really good question. They do slightly change, but there's not a lot of variability. We're going to talk a little bit later on about the lung volumes and the lung capacities, and they're usually pretty fixed. Like if I take a deep breath in, I can add some more breath onto that. It's called a forced inspiration, but it's not by a whole lot. And those volumes are pretty constant or pretty defined based upon general physiology. Okay, hope that helps. Okay, and then we've also got our expiratory muscles. These help to decrease the volume of the thoracic cavity. These are going to be the internal intercostals and then the abdominal muscles. I want you to make a very important asterisk here that for the most part, expiration is a passive process. So only during forced expiration do we really call on the internal intercostals and the abdominal muscles. Usually as we quietly expire, so as you're sitting quietly and you take a nice big deep breath in, the diaphragm and external intercostals help to change the shape of the thoracic cavity and increase the volume of the thoracic cavity. But then when you quietly expire, you're pretty much just undoing by relaxing the diaphragm and external intercostals. And only when you are forcefully expiring, and you can probably try to do this where you are sitting right now, just try to kind of push air out of your lungs, you can actually feel your core abdominals, like your rectus abdominis engaging. But when you are quietly expiring, you actually are not using any muscles. You're just passively doing so as the diaphragms and external intercostals relax. Okay. Okay, another really great question here is the alveolar pressure looked at by doctors to determine lung health, or do they just look at oxygen levels? They definitely do look at the pressures. Yes, we'll talk about that a little bit later on. They do look at the pressures. They do look at the volumes, right, which are influencing the pressures to determine lung health. Okay. All right. So here's an image showing that we've got the external intercostals, and from lab, we should know the orientation of these fibers. They're down and in, think about hands in your front pockets, whereas the internal intercostals are gonna be down and out. So think about hands in your back pockets, kind of the analogy I like to use. We've also got the diaphragm, right? This curved or dome-shaped muscle inferiorly here. And then we've got the abdominals, the rectus abdominals, or the anterior abdominal muscles, okay? And so the internal intercostals and the rectus abdominal muscles are only used to forcefully expire, whereas inspiration is going to contract the external intercostals and the diaphragm, and expiration, quiet expiration, is simply going to relax these muscles, okay? And what we're really doing with these muscles is simply changing the shape of the thoracic cavity. Because of the curvature of the ribs, right? When these muscles contract, this flares the ribs out, flattens down the diaphragm, and kind of opens up the thoracic cavity, makes it really nice and large, and by extension changes the volume of the alveoli and the pressure in the alveoli, as we talked about before. We also want to think about some of the influences. So if you're having difficulty breathing, right, if you're having respiratory distress, you can call on some other muscles that we talked about in lab as well. So your sternocleidomastoid, some of the infrahyoid muscles or the neck muscles, the scalenes, because they do attach to the manubrium, they can also manipulate the shape of the thoracic cavity. And so usually when someone is in respiratory distress, asthmatics, or someone with COPD or emphysema, they'll usually exhibit what we call tripoding. So they'll lean down on their knees and they'll really try to engage these neck muscles as a way to really manipulate the shape of the thoracic cavity. And they can use those accessory muscles of respiration, especially in times of respiratory distress, okay? Okay, so another illustration here showing that relationship during the different phases of respiration. So we see the external intercostals, the diaphragm flattening out as a part of inspiration, really opening up, expanding the thoracic cavity here. We can see this nice large barrel-shaped chest. This is what's going to manipulate, again, I keep reiterating this relationship, it's going to be adhered to the lung via that pleural connection. So as I first contract my external intercostals and my diaphragm, I intentionally pull on that pleural cavity, and that pulls on the lungs. That increases the volumes in my alveoli, and that decreases the pressure in my alveoli, and that creates a gradient for airflow from high out in the atmosphere to low down inside my alveoli, okay? On the other hand, expiration, usually a passive kind of recoil of these muscles. So as the external intercostals recoil back into their original position, the diaphragm recoils back into its curved position, I make the volume of the thoracic cavity smaller, right, visibly smaller, as we can see here. By extension, because of that pleural connection, I make the volume of my alveoli smaller, which, again, because of Boyle's law, I increase the pressure within the alveoli, and I reverse my gradient. So now I have higher pressure in the alveoli, lower pressure out in the atmosphere, and I can now facilitate air moving out of the lungs and into the atmosphere, okay? And then just to reiterate here, during times of forceful expirations, if I'm really trying to force air out, I will engage the abdominals, as you can probably feel when you try to do that, as well as the internal intercostal muscles in order to actively or forcefully expire. All right. My inspiration is usually involving neural stimulation. Does anyone remember what nerve innervates the diaphragm? We talked about it in lab if you had your lab already. The nerve that innervates the diaphragm. Okay, so it's actually the phrenic nerve. Okay, so I saw some other options here, the vagus, and it's not the vagus. The vagus does not innervate skeletal muscle. Remember, vagus is a sympathetic nerve, and so it's not going to have influence on skeletal muscle. Remember, the diaphragm is a skeletal muscle, external intercostals are skeletal muscle, and they are innervated diaphragm by the phrenic nerve, which we talked about, that peripheral nerve running on the outer aspects of the pericardial sac. And then the external intercostals are actually innervated by the intercostal nerve, right? That nerve that we talked about, that runs along the inferior border of the ribs, okay? So these are somatic nerves, right? Innervating skeletal muscle. And they're gonna innervate or contract these muscles, which will change the shape of the thoracic cavity according to what we just described, okay? And so they change the volume of the thoracic cavity by changing the shape. And so as we pull on the pleura, we decrease the intrapleural pressure, and by extension, we increase the transpulmonary pressure. So I talked about this relationship earlier, the fact that transpulmonary pressure is actually our intraalveolar pressure minus our intrapleural pressure. So it only makes sense. If I make that intrapleural pressure a smaller number, I am going to make my transpulmonary pressure a bigger number, right? Because it's the difference between intraalveolar pressure minus our intrapleural pressure. And so as I do that, as I increase my transpulmonary pressure, we also describe that being our distending pressure. So I make it more easy for the lungs to distend as I increase my transpulmonary pressure. And that happens when I decrease my intrapleural pressure. Okay, so I can expand the alveoli, which will further drop the alveolar pressure, facilitating that gradient where air can flow into the alveolar according to those bulk flow principles.